Worthen, the TOS guy. Welcome to our next live stream. We have a special guest today, a first-time visitor. Before we start, I'd like to remind everybody, please subscribe. That helps the algorithm, I've been told. Click like as many times as you like, although I'm sure only one will be accepted. And make sure you follow us on all our social media so we keep raising awareness of TOS. Our talk today is with a good friend of ours, Rob Hagan. Rob is a plastic surgeon of all specialties, specialized in peripheral nerve surgery, working in St. Louis, Missouri. And Rob has a really unique approach to TOS, which carries a tremendous amount of value, in my opinion. You're going to find out exactly why that is. We're also going to try a different kind of approach. Rob has a great presentation, but I'm going to stay on with him and I'm going to poke him and prod him with little questions and discussion points as we go along, because Rob and I have discussed TOS many times. Isn't that right, Rob?
Absolutely.
All right. Well, thanks for coming to our show. I'm really looking forward to your talk.
As you know, you and I have, this keeps clicking off, so I'll try to continue watching to make sure I don't go on mute. But you and I have enjoyed multiple discussions about TOS, and hopefully today will just be maybe a summary of all those discussions in the past. I've brought some slides that again you have been willing to stay on and prod me a little bit about some of them, and hopefully that'll again give us additional fodder for ongoing regarding this topic. Herb, that mute button still keeps clicking over, so I don't know if we can work on that. But so as Scott said, I'm a peripheral nerve surgeon, and we wanted to talk today kind of via our optic of thoracic outlet through the eyes of a peripheral nerve surgeon, right? Most of the time, a person addressing TOS is a vascular surgeon, but I'll summarize today why my particular interest in neurogenic thoracic outlet evolved over time. And as you can see, I'm a plastic surgeon trained. I did a hand and microsurgery fellowship. I did a craniofacial fellowship as well. All that training kind of serendipitously prepared me to be a peripheral nerve surgeon, kind of head to toe, with one of my focal specialty areas being the neurogenic thoracic outlet syndrome. As you can see, this is a spectrum of my practice: hand surgery, peripheral nerve, do some reconstructive surgery, a lot of surgical pain management kind of solutions, which is a lot of the peripheral nerve problems. And we even integrate some biologic and regenerative kind of techniques into our process as well. When you think of peripheral nerve injuries, just the basic things are, right, you can cut a nerve, you can crush a nerve can be compressed, or you can have a nerve neuroma. And I just share this with just kind of, let's paint a big picture about peripheral nerve surgery, right? Carpal tunnel is the most common compression neuropathy that we know. But in reality, neurogenic thoracic outlet is actually a compression neuropathy in its own right. The predominant component of it is just that. We, as peripheral nerve surgeons, if a nerve is compressed, we can decompress it, right? If it's damaged and it's a sensory nerve, we can excise it. I always say if it's doing more harm than good, you can get rid of it. You can repair nerves. Unlike the central nervous system, the peripheral nervous system repairs itself, right? So when we do a nerve repair, it can grow back down that same conduit and reinnervate skin and or muscle. And then we can transfer nerves, much like old tendon transfers. We can now use nerve transfers. So that just gives you an idea about what is in the tool belt of the peripheral nerve surgeon.
Rob,
and I just thought that, yeah.
Hey, Rob, to go back one step, you talked very briefly about a compression neuropathy, and this is something you and I have discussed. Can you define how you approach a compression neuropathy in theory and give a couple examples?
Sure. I mean, again, a compression neuropathy is a pinched nerve, right? And again, the most common carpal tunnel syndrome, cubital tunnel syndrome, tarsal tunnel syndrome, all of those are compression neuropathies. Um, Compression of the lateral femoral nerve at the groin, myalgia parasitica, compression neuropathy, right? Um, you there's a kind of a standard logical approach to each one of those and diagnosing it. Sometimes it involves just clinical examination and history, right? Every time we, or as a peripheral nerve surgeon, see something, we look at what was the mechanism of injury, what are the symptoms, what are the distribution of the symptoms, what's the physical examination show us, what are the other additional testing show us, MRI, electrodiagnostic, ultrasound, and then diagnostic injections. So that's that logical stratified approach to each one of these, whether it's carpal tunnel or a complex neurogenic thoracic outlet, is kind of how we approach that. Is that answering that question?
So by considering a compressive neuropathy, which occur in traditional places throughout the body, whenever the nerve goes through a tight tunnel, it's not everybody who considers neurogenic thoracic outlet syndrome as just another example of that disease, maybe a more complex one, but
Yeah.
you do. Yep.
Yeah, I mean that's part of its pathology for sure. I mean, again, you have to look at some of the arterial stuff that we're going to talk about. You can have a regular non-aneurysmal vascular structure that is still getting kinked or compressed, right? And the evolution of our technique, we spend a fair amount of time just doing what we call not just the neurolysis but the arteriolysis of at that scaling triangle. And so we can talk more about that as we
Good.
continue
Thanks.
on. Great question, thank you. Just a little thing about pain, because the number one thing that usually drives people in for neurogenic thoracic outlet is their pain, right? Whether it's an occipital headache or facial pain or neck pain or pain in their extremity or pain in the back. So from my standpoint as a peripheral nerve surgeon, understanding pain and kind of embracing, not running away. We were often taught to run away from pain and at least chronic pain, right? And it's many times the final limiting factor of people getting. I always talk about getting back to sleep, back to life, back to work, right? So those are the ultimate goals for us, and in peripheral nerve surgery, you can't do that until you get rid of the pain, right? People can tolerate numbness, people can tolerate some weakness, but when they're not sleeping and they're in chronic pain, and you're not fixing it, you're failing this patient, right? Let's put in perspective the TOS, right? Neurogenic TOS, and the whole complex of the upper extremity and arm, right? When I'm seeing and evaluating neurogenic thoracic outlet, I'm also looking at all the other nerve compressions in the upper extremity, right? So we're often evaluating, is this coming from the spine, right? So we have to rule in, rule out if there's any spinal pathology, but we also have to rule in and rule out everything downstream from the plexus as well, right? Whether it's pectoralis minor syndrome, whether it's radial tunnel, pronator syndrome, carpal tunnel, all that, because if you don't address that, and let's say you even do your TOS surgery, right? You treat that, but you still have a numb hand and painful hand, and you missed carpal tunnel or you missed a pronator syndrome, right? So comprehensively understanding the whole limb and all peripheral nerve compressions outside of the spinal axis is, I think, value added importance.
Not to mention multiple crush syndrome.
Right. And that's what that would be, right? I mean, if you had a pronator syndrome and a cubital tunnel syndrome and you had thoracic outlet, that's a multi-level crush, right? And it happens more than you think, right? We're often diagnosing these distal compressions as well as the NTOS, and then having to decide, okay, which one are we going to do first, right? Because it's often confusing to parties involved that are trying to dictate care for these individuals, right? And
Do you find that sometimes you treat the more proximal neuropathy and you don't have to treat the distal ones after that?
in some, yeah. So if we can prove to ourselves that we think more of the symptoms are emanating from proximal, we'll do proximal first, right? If it's more confusing, or we think that that it's more from the distal, we'll focus distal. We'll do decompression of the distal, and then we're back to like, okay, let's try some injections and therapy on that more proximal pathology than NTOS. Every pathway exists. You just got to find out which. I always say we have to be patient centric. We have to customize care to every single one of those patients so that we can get the best outcome for them. Right? It's not about us; it's about them. Right? So a lot of fun to discuss that. Right? Sorry, little coffee action. This I put this in there because we all know, like when we start talking about thoracic outlet syndrome, we all know that 95% of them are neurogenic, right? Small percentage are venous and even a smaller arterial, right? Doesn't mean that those structures aren't involved in the scaling triangle, and we'll talk about that. But a large number of these are neurogenic, and like we said, it's a nerve compression. And so we have to figure out that. And that's what got me interested when as my peripheral nerve practice was evolving very early in my practice. I started to ask the question about when I understood that 95% of these were neurogenic. I'm like, how come we have peripheral nerve surgeons that aren't more involved in this, and that the vascular surgeons were largely taking care of these patients? And I just thought, hey, we're bound to have a different optic and maybe some help in improving overall stratified and longitudinal care for these patients. So that was a bunch of years ago.
So that's a really great point, Rob, which I've discussed with many patients and other docs. I'm glad you brought it up. This is a very complex anatomic area. A lot of surgeons are hesitant to go there because there's so many important structures. But over time, vascular surgeons have kind of taken the lion's share of the knowledge of it, as it were. And
they've made good contributions to this problem, right?
Yep, but it's based on a minority of the disease.
Yeah.
So
right.
they approach neurogenic the same way they would approach a subclavian artery aneurysm. And
right.
maybe that leaves open a lot of possibilities because it is a different disease with many causes.
Right. And I think our challenge has been to suggest that maybe a little more stratified care model might be appropriate. And we've been working long and hard on that. I put this in here because I think, often when I'm talking to other clinicians, other providers about, they say, I don't really see it that often. And I say, well, even in my practice, look, I mean, here's a list of how these patients have presented to me, just generalized trauma, whiplash, they've been accosted, they're the generic headache patient that shows up in my clinic. They presented it with carpal and cubital and lateral epicondylitis and generalized shoulder pain. So these patients are out there, and part of our burden as TOS providers, right, is that we have to help them identify triggers to understand, like, okay, no, that actually might be a TOS patient because the MRI of the shoulder is pretty negative, the spine's negative, but they've got they got shoulder pain, they've got limb numbness and tingling. So, there's a couple things that we can help them identify these patients. The TOS team, often includes the shoulder surgeon, the C-spine surgeon, physiatrist, the neurologist, the radiologist, right? So those are common dialogue, common interactions that help identify these patients. Here's kind of the talk about the historically, 95% of these patients are neurogenic, and nearly 95% or 100 are sent to vascular surgeons. And when I started this out, are we doing a vascular surgery for a nerve problem? Was just my simple question, right? And so over time, our technique, as you know, has evolved. We tend to focus, we're now down to an outpatient surgery that focuses on the composite of structures in the scalene triangle and the pectoralis minor in most cases, right? We 5 to 7% of the time may remove a rib. And we'll talk more about that as we go along. Here's the classic picture. I love this picture. It kind of breaks it down to the 3 points of the potential compression. Anytime you're talking about neurogenic thoracic outlet, you should think about these 3 really sub-diagnoses, right? You have scalene triangle syndrome. You have costoclavicular space syndrome. You have pectoralis minor syndrome, right? And we believe, again, that 95% of the time that addressing scalene triangle and pectoralis minor, you will, in the majority of the cases, convert people to doing much better. Excuse me. So scalene triangle is variable in how people think what's associated with it, right? It's the anterior scalene, it's the middle scalene, it's first rib, but it's also those structures associated with it. And early on, we adopted, the classic, upper trunk, middle trunk, lower trunk, as you can see here, of the brachial plexus and the subclavian artery, all within the contents, right? But you'll see, and as we talk a little bit later, also part of that is the dorsal scapular, suprascapular, and the long thoracic nerve. Those are all the contents of the scalene triangle. Costoclavicular component here, first rib and the clavicle. Here's the scalene triangle. The pectoralis minor, right? Is very dynamic, right? Pectoralis minor inserting into that coracoid process. I still, to this day, it's so consistent that the pec minor is involved. And it's so consistent that people are just focally tender over that insertion site. And I don't get how it is that often, right? When we first started developing our technique, I'm like, surely, I bet you about 50 would be, pec minor and not. It's nearly 100%. And now we're just down to differentiating to determine, what's applying most pressure, what's kinking the artery. Is it the scalene when we're provocative motions? Is it at the scalene triangle, or is it the pec minor? But clearly we're seeing more and more even arterial compression at that pec minor insertion core. Yeah, it keeps coming off. I don't know why.
Okay. So this brings up a great point. Oh, lost your audio. There you go.
So, and then just real quick on the anatomy, and then we'll. One of the real important evolutions that we've had is to release that. There's a dense clavipectoral fascia that comes down the side of the pec minor, and it can fuse with the coracobrachialis. So you really have to make sure and release that, or you'll have an incomplete release at the pec minor. And then the other thing we do is we divide that. I have talked about, about the importance of that subclavius muscle and that subclavius posticus morphology or anatomic variant. And I've seen more and more of those as we've evolved and really look at that subclavius muscle as well. So just another interesting point. You were going to make a point, Scott, with the anatomy. I'm sorry.
It's great that you bring up the pec minor, the scalene triangle. As we know from the literature, I've cataloged these on my website. There's like 26 different names from different authors over 200 years doing different techniques, different provocative maneuvers. We know the anatomy in any single person can be so variable that the nerves can take different courses relative to the scaling muscles, that the scaling muscles may overlap and narrow at the bottom where they attach to the first rib. They can form a sling, that we have scaling minimus muscles and other variants. And so your detailed approach to me resonates greatly. And the fact that you have these results with very few rib resections is very encouraging to me, because the standard, as most of our viewers know, is thoracic outlet syndrome, rib resection. And I don't think it's always that automatic. So that's what we see in the literature. I also want to bring up about the pec minor, and I'm sorry, this is kind of a multi-layered point. The literature for radiology is scant, but it doesn't show that there's compression behind the pec minor. It actually shows that people without disease have a narrower retropectoralis space than people with TOS. And so I'll ask you a dumb question. Historically, do you know when the first pec minor tenotomy was done? Do you have a wild guess?
No, I mean, I've seen that referenced in, but I don't remember it off the top of my head.
1950, a guy named Jerry Lord, who was famous for a lot of
Yes.
things, and 1950, and he didn't know why it worked, but you and I both know it works, and we both don't know why. I disagree with the most literature that says the plexus is compressed there. I think it's more likely that there's an imbalance of shoulder muscles, and that the pec minor is tense, as you notice, very tender. And when you inject blockade into that muscle, you often get relief of symptoms, I would bet. Lost your audio.
We largely do injections, diagnostic and therapeutic injections for most all patients, and we always inject that pec minor. It always contributes, and I even went through a period of time where I would inject the pec minor first and then retest them and just see. A component, most of them, a component would get better, but then they'd still be tender at their scaling triangle. They'd still have a Tenel, so. But it proved to me that there's still a component to it, and I had to differentiate and convince myself of their independent involvement, I guess.
Now, also you brought up the clavipectoral fascia. For the viewers, the fascia is like these layers of connective tissue, sort of like thick paper, fibrous tissue between layers of muscles, and the clavipectoral fascia wraps up the pec minor.
Mm-hmm.
So that association may be treated. I've never met another surgeon who addresses the clavipectoral fascia in every patient. So maybe that's why you have good success.
Yeah, well, I think just like I said, it's part of the tunnel. It's the composite of all these things that are adding up, and 1 + 1 + 1 is 6.
Right.
On a bad direction, right?
Right. So maybe when you blocked the pec minor muscle, you couldn't get rid of all symptoms because maybe it wasn't the initiating point, but it was a secondary mechanism. I don't know.
Right. I don't know. And for me, this is just an offshoot. This is why I love having these discussions with you. I've also thought that releasing that pec minor, because it's usually tight. I think people hold their shoulder, hold the shoulder forward and down to relieve some of the symptoms. And by releasing that, you're allowing that shoulder to come back up into a better position. You're also elevating the clavicle, right, which opens that costoclavicular space. That in conjunction with releasing the scalings off that first rib, and I'm a believer that first rib drops a little bit once you release the scalings off of it, right? So the composite of raising that clavicle and dropping the first rib sometimes converts people from, even if they're in a gray zone of maybe they need a first rib out, but we've opened up the space. I think that's meaningful.
Great. Those are great points.
This is just a slide to show you, again, early on, we'd be so excited. Patient come back in and their arm and their hand would be feel better. But they were like, "Doc, I still got posterior shoulder pain." And I was so frustrated by that. And I couldn't figure out why. And I'm like, well, what nerves are going to there? And so we kind of demarcated out that, the the kind of the medial border of the scapula is the dorsal scapular pain. Scapular pain in general lined up with suprascapular nerve, and then this generalized from the scapula down into the axilla and on the chest wall, matched up with the long thoracic nerve. When we started adding these in and to our evaluation and ultimately into our surgical treatment, largely that posterior shoulder pain started to go away, and we were becoming more successful at treating that. I'll see patients that have had, a TOS surgery and when they have just that posterior shoulder pain, I'm much more open to evaluating them to see if that's just what they need. Maybe perhaps they had a very good, decompression for their traditional TOS, but posterior shoulder pain will block these nerves under ultrasound, and if they get better, we'll go neurolyze those for them as well. So it's kind of
Are they hard to see during your surgical approach?
Yeah, sometimes. Yeah, sometimes I'm wishing I wouldn't have done it. It's a tough dissection in any secondary plexus or neck surgeon, I would say. But we've gotten better at it over the years, and we're very selective. But I think those who have had us do it, I think would say they've had significant benefit.
So this is another example of where a peripheral nerve surgeon takes a different approach. You're so used to dealing with tiny nerve branches and small nerves and dissecting them along their courses. No audio, Rob.
As we talked about earlier, I think, I love the old joke. What's the most famous fiction book? Grey's Anatomy, right? Everybody's just enough different. You have to keep that in mind, right? If in order to customize and provide true, kind of custom care for the individual, you have to take into account all the anatomic variability in these nerves, right?
Which, by the way, if I slap myself on the back, is a great reason for doing an MRI.
Oh, absolutely. I don't know. You've made great contributions in this space. I love your energy about it. I love your database. You understand this as good as anybody I know, and just love having even this discussion with you.
Well, this is so we agree on this. Peripheral nerve surgeons take a very, very detailed approach for many problems throughout the body. And, as radiologists, part of our job is to understand what the clinician wants. And there aren't many clinicians who I've seen who need and demand that high level of detail. But once I understand how you approach this, I remember I met you at the meeting, the peripheral nerve surgery meeting, and it's just great how you guys take so much detail into mind. It's just hard for radiologists because we really have to know that little area in incredible detail.
Well, you've done an unbelievable job. So this is just this will kind of put in perspective a little bit about what I think kind of goes on, right? So in most of these, in the component of injury, when we're looking at TOS, we have scalene fibrosis, right, which affects the plexus, the traction point of those accessory nerves we just talked about, primary pain from traction and elevation of the first rib, right? So traction on the meaning there's tethering of that and compression on the nerve and really the artery, right? The brachial plexus tethering and compression we talked about that thickened rind earlier on that, I believe that comes from probable perineural bleeding, right? And the body resorbs that, but it leaves behind this fibrosis that I usually call, it's kind of like a thickened shrink wrap that acts like a Chinese finger trap, right? And you lose the gliding surface. And most people don't think about gliding surfaces of nerves, right? I mean, the tendons need a gliding surface, nerves need a gliding surface, and nerves are very sensitive. They don't tolerate not having it as much as, say, tendons do in the forearm, right? And then we've kind of talked a little bit about the pectoralis minor syndrome, and then go back. Sorry, there's something right in my way. I can't see there. But the subclavian artery has been an evolution for us too. The same process that goes on around the nerves actually goes around the arteries, right? We see this thickened fascia around it, and we're cleaning that off, much like when we used to do, like, it's almost like a sympathectomy of the artery, right? I've now call it kind of an arteriolysis, because I think that fits more appropriate with the neurolysis, right? But we're doing the same thing. We're cleaning that off, and I think it's made a significant difference in our outcomes. When we talk about symptoms, one of the most odd things that people forget about is an occipital headache, right? In this old Sanders paper, 76% of people had an occipital headache, right? And we do a lot with occipital neuralgia, but in this patient population, they'll tend to have an occipital headache right here. It doesn't tend to activate and come over like classic occipital neuralgia. So that's the first kind of big picture differentiating we're looking at. We're looking at the pattern of that occipital headache, and differentiating, because again, many of these patients, not many, some subcategory of these patients have both an occipital neuralgia and a neurogenic thoracic outlet. So when we just look, that's just one symptom, right? But as you know, you can have shoulder pain, periscapular pain, extremity pain, facial pain, ear pain, jaw pain. You can have numbness, tingling, and weakness of that upper extremity in any degree or any distribution, right? So when I'm talking to other care providers, the shoulder, the physiatrist, the spine surgeon, I'm like, if you're confused by the number of symptoms, right, and the mechanism of injury and all that, like, start to think about that. Your MRI is negative, or you're looking for a soft call on an MRI C-spine, and your shoulder MRI is negative, but you have all these symptoms. You need to look at the idea of TOS, right? Is that a fair? Would you say that's a fair summary?
That's a great point. It's like when you can't pin down one radiculopathy and you have these associated things of chest pain, vague things that can't be defined by the territory, occipital pain, right? That should be
Right.
triggering your bells and saying, maybe I should be looking at TOS. And I think most of our patients who view this have had those episodes where they just don't get why they're having all those symptoms together. So I think it's a great point. Your audio is out, but also,
Yeah. The average patient that sees us has seen 6 to 7 providers before they find us with this diagnosis.
It's a shame.
Yeah.
And I'll tell you, when I first started this 25 years ago, patients were going 10 or 15 years without a diagnosis. And I'm so glad, thanks to people like you, that it's really been shortened. We're really seeing a change in awareness throughout the country.
Well, it's a team effort. I mean, this platform alone helps a lot of people.
Well, it's what we aim to do. I think patients are now driving this, don't you? You must get some patients that come to you and tell you they have TOS.
They do. I just had a patient. Every day I learn more about. I mean, I'm a fan of, but I'm not a big. We had a young female who I did headache surgery on, that did a TikTok on her experience, and it was a great story. She had 32,000 views. I said, her impact, she paid it forward. She touched lives of people that wouldn't, it's just so cool. And when you see things like that happen, it's well beyond us. We're kind of slugging away in the trenches here, and for a patient to be that creative and come up with platforms and methods to get people to the right place is pretty cool.
I'll tell you, Rob, some of the questions we get here from our viewers, which you will see, we get some amazingly sophisticated questions.
Yeah.
People use Dr. Google and they go hunting and they do social media and they find out stuff that's amazing.
I absolutely love it. The patient that comes in that's just hyper analytical and is just every patient, and they're just asking you just such great questions. I'm like, I learn from them. You can never be afraid and never be too proud, right? And we
I hear you.
all have such great access to more information than we can get through. So I always say, just keep packing the snowball, man. If somebody gives me some snow, I'm packing it in our snowball.
Great
So,
way to put it.
all right, let's keep going. You and I talked about just the importance of examination. I think, understanding that, the concept of can you hear me?
Yep.
Okay. The concept, so many times I'll see another person have seen, let's just even say a general neurologist, and maybe they had a general neurology examination. And then it kind of just gets written off that, well, there's no nerve problem because the general neurology examination was negative, right? And despite them doing a very thorough and good central neurologic examination, there was no focused physical examination on the peripheral nervous system, or specifically the TOS, right? And so I'm often having to politely go back and point that out. And so examination is important, and these tests right here are not part of a general neurologic examination, right? I
Right.
mean, these provocative maneuvers put people into to determine, right? Is that, I mean, and these are determining, is that brachial plexus tethered like we talked about? Is it stuck in? Does it have a Chinese finger trap on it up at the scalene triangle, or is this the fulcrum of pressure underneath that coracoid? Is it evoking and augmenting their symptoms and making it worse, right? This is what we do is for our examination, right? Whether it's the modified upper limb tension test, whether the East, the Addisons, the Allen, the Wright test, the supraclavicular pressure test. We look at all of them. The costoclavicular maneuver. I use the costoclavicular maneuver a lot in helping me differentiate whether or not that person is going to respond to just our soft tissue kind of release versus do we need a rib removal, right? So examination is important. Our overall protocol, involves the peripheral nerve consultation. We have a wonderfully bright PT person that is part of our team. We do an electrodiagnostic test, not to diagnose neurogenic thoracic outlet, because it doesn't. We use it to make sure we're not missing something upstream in the cervical spine or downstream, like we talked about, carpal tunnel, cubital tunnel, radial tunnel, all these other things that it may or may not pick up. Again, radiologic studies, you're the absolute guru on MRI. I've not found anybody to provide the detail that you do on your studies, and that are more meaningful. You may even use just basic C-spine X-rays, right? I mean, just rule in or rule out a cervical rib. Our diagnostic blocks are a big part. If you make it through all the other pieces, and I still think the working diagnosis is a neurogenic thoracic outlet, we're going to do our own, and we've done our own ultrasound guided injections since probably about 2008.
Great.
Over the years, we've gotten better and better, and we've talked a little bit about that early on, and we're now getting both qualitative and information, as well as being a better injector or diagnostic block. All those things are meaningful in our protocol.
So to emphasize what you said, if you could go back a second, you got a patient who's had a really nice workup from a good neurologist, including the standard neurologic exam, and you still don't have an answer. What you're doing now, provocative tests, all these tests, the East test, the Ruse test, the Addisons, especially the upper limb neural tension test, these are not part of a standard neurologic exam. So it starts because you have an index of suspicion that it's TOS.
Right.
And then you eventually graduate to these blocks. So I hope people understand that when a doctor tells them you couldn't have TOS, that should be only after they've had a workup as extensive as yours. You're very thoughtful. You're not leaving any stone unturned, but it takes you many tests to eliminate things. and to focus down on TOS. So I think there's a great description, a great example for patients about how thorough their doc needs to be before they say it can't be TOS.
Right. I mean, because we want to be right for the patient. We're not right for us. We'll be right for the patient. What feels good is to establish an accurate diagnosis, right? And then go. And if we're gonna recommend surgery, we want to have the highest index of suspicion that we can achieve, at least for them, that they're going to be a responder. We're not 100%, but we're trying to be, right? And so all these things, each one of these things is meaningful and thoughtful. And it's within that. Remember, we talked about the process of every time I'm looking at onset or mechanism of injury, I'm looking at the symptoms, I'm looking at the distribution of the symptoms, I'm looking at the focused physical examination. If then we have still think that that's the diagnosis, we then move on to more additional studies and other consultations to further confirm that. If those also support that, we then go to more times than not is the diagnostic injections, which have both diagnostic and as our practice is evolving, I'm seeing patients earlier and earlier, sometimes as early as 6, 10, 12 weeks after the injury that can cause that. All of a sudden, those diagnostic injections have a very significant potential therapeutic component to them.
That's great.
So that's been a lot of fun to show that the earlier we see those patients, we may be obviating surgery.
So that's a value of awareness. If patients know or docs in your community know, and they suspect TOS, they get them to you quickly, and the outcome is hugely different.
It is. Yeah.
Do you do hydro-dissections at all? Have you read about them, or do you do them?
Yeah, no. We most times when we're doing that, I'm hydro-dissecting, and again, this is an evolution. Remember, we've been doing this since about, like I said, 2008. So we've gotten better and better and better. At this point in time, I'm usually hydro-dissecting upper trunk, middle trunk, and lower trunk. I've hydro-dissected the lower trunk off the scalene artery, right, and pop that plane open.
So
if we are able to do that,
people what that is, I know we're using medical words, but
what's that?
For our viewers, can you describe what a hydro-dissection is?
Yeah, it's just, so if you have a plane that's normally moving or has some level of space or has some fat in it, right, and it's scarred down or stuck, and you get your needle into that space or potential space, and you inject fluid, say 1% lidocaine, and it pops that plane open, right? You've hydro-dissected it with fluid, right? So we use that around nerves quite frequently. And if we're able to, and then when you look at it on a cross section within the ultrasound screen, you'll see it's kind of like a halo around that nerve, right? And then in that halo, what we'll do is come back through and put a little steroid in that halo, right? And in some cases, we'll actually inject a little structural fat graft in there in very unique cases. So, but that's a whole nother topic. But
excellent.
Yeah. Good. Shall we move on?
Yeah, I'll just bring up one more thing about that. I have met a few people who will use things like 50% dextrose. Just recently, I heard about somebody, I have not spoken with this doc yet, who uses hyaluronase. But the idea is what you've discussed before about the nerves not being able to glide because of scar tissue. And then this is one way, a non-surgical way, to try to reverse that. So it's fascinating to me. It's really fascinating. I'd love to talk more about the details.
Yeah, well, let's talk more about it because I like that idea. It's the same. It's kind of, are you digesting or softening that fibrosis and reestablishing? And steroid does that a little bit, right? Steroid helps dissolve and decrease some of that sticky fibrosis, but there's potential uses for other agents.
I've done PRP myself, actually.
Yeah.
But not often enough to make any good judgments about it. But the same idea, we're still trying to figure out some of those bioactive substances.
Yeah, I'm a fan of the biologics, and when you're utilizing, you can utilize PRP, you can use bone marrow or BMAC, you can use structural fat grafting. Fat has the most stem cells in it than all three of those. The stromovascular component of fat is loaded with stem cells, and we think that there's a good, what we call a paracrine effect, right? And just for everybody listening, paracrine, like if you put stem cells in an area, they're spewing out or emanating little signals and healing factors that help induce healing and good tissue growth. So just the paracrine effect alone of those cells being in the area of the injury or what you're trying to change has proved to be very, very beneficial. We work closely with a group called Blue Tail Medical here in St. Louis. Dave Crane, who I have a lot of admiration for, has taught me a lot about biologics over the years. And we've tried to apply that to nerves, especially these tough nerve cases we're seeing where there's scar tissue and neuralgias, and we don't know that just blasting back in with surgery is gonna help. So we've tried to, again, keep that in our tool belt as part of it.
Great. One of the reasons we recommend patients to see you and reach out. At this point, I'm just going to interrupt briefly and remind people, subscribe or hit the like button for us. Please help us out. All right, let's go on to our imaging and whatever we're doing next.
Well, I just put this here as a space marker, right? And we've really talked a little bit about already what your contributions have been to helping us and everyone else differentiate what's going on with the nerves and the muscle tissue and the anatomic variants. This will continue to prove to be so important, I think, and just in the evolution of all of ours, no matter what technique or approach you're using it, your contributions in understanding how well we can see that, I think, will push everybody forward. Ultrasound, we kind of talked about. Again, I've been doing it since 2008. We do all of our own injections. We block and inject the anterior scalene, the middle scalene. You can see here, like there's the trunks, right? And you can imagine getting the needle in between the muscle, this fascial plane here, and the nerve. And if you can push fluid in there and pop that open, then you have a nice plane to put some steroid in there as well. I think that's been beneficial. And I think we, to this day, convert some patients that were on the surgical pathway and obviate surgery and get them down a pathway of non-surgical treatment, which we're quite proud of. So how much time do we have? Just
we're good. We keep going as long as people want to watch us.
Good. So conservative therapy, right? We talked a little bit about physical therapy modalities, medication, blocks, and steroids. We've kind of covered those. Something that is growing in our practice, and especially since we are seeing some of these patients earlier, right? I think Botox is a very useful tool. If they had a whiplash, whatever, 12 weeks ago, and things are not calming down. They've got that tight, tense, achy feeling, and they responded well to an injection, right? Then we'll interject to the idea of Botoxing that anterior scalene, the middle scalene, and actually I have anterior scalene muscle there now. We'll anterior scalene, middle scalene, and the pec minor, and to really kind of let those things kind of loosen up and not be so kind of spasmy, so to speak, right? So those are some basic conservative things that we'll do. Whether it's worthwhile talking about indications for surgery, intractable pain, failed supervised physical therapy programs, significant neurologic deficit and persistent symptoms after more distal decompressions. And that's an interesting one, right? Because sometimes we had this discussion a little bit earlier offline when there's distal decompressions. I guess we did. We actually did cover that, didn't we? When
Yeah,
we
we
were
were talking
looking at
about
the arm,
multiple crush
right?
here, yeah.
Just whether or not you're doing distal versus proximal, and trying to differentiate which one you're going to do first, right? So all those things come into play when we're thinking about doing that. So I think that one of the topics I think you and I wanted to cover today was no rib resection, right? So it's not that we don't do any rib resections, right? It's just we go back to that whole idea of are we doing a vascular surgery for a nerve problem, right? Can we stratify our surgical care better and still get the same or better outcomes, right? And that was the question. And there was literature. I mean, we're not the novel person to say, hey, no rib resection, you can still treat. But there was enough literature that made sense to us to say, hey, like, if there's no true costoclavicular component to this, how come we can't just treat the soft tissue components and see what our outcomes are? And we believe that 95% of the time, about 95% of the time, that's going to be, let's even say it's 90. Let's even say 9 times out of 10, you don't need to remove a rib. It's not 100% of the time. And we do primary first rib resections, right? If it's clear to us that the costoclavicular component is significant enough, or if it's the primary problem, we're going to go take the rib out, right? But if not, if we can't prove that, we're probably going to do the scaling triangle plus the pectoralis minor at first, and see if we get convert them into doing okay, right? What does that mean? And how I present that to patients is, maybe as high as 5% of the time, you're going to have a second surgery to remove the first rib, and we do that through a transaxillary approach. Most people are willing to bet that they're going to fall into the 95%. I would. I mean, that's how I designed it. That's how I would do it, right? So we're just trying to be thoughtful and polite discussions about, hey, let's stratify care better in the nerve-related one, right? If you have an aneurysmal, artery or Paget-Schroeder vein, like that rib is likely the fulcrum and needs to come out, right? There's no doubt about that. The question here is, what is the true percentage of ribs need to come out in neurogenic thoracic outlet? And not enough people ask that question.
Yeah, we don't have the answer for that right now.
So
what you're showing here, if you go back a second to the graph, is the results from doing a rib resection. And I'll just reinforce to people, after surgery, it's about 85% of people feel better. And I think the literature generally agrees by 2 years, about 70% of people are better. So we're failing in 30%. So there are many reasons why that could be. I don't think it's because surgeons don't know what they're doing. I think surgeons are really good at taking out the first rib. But I think, my opinion is, we have a very heterogeneous disease here. And as Rob is saying, the first rib is not the cause of disease in many of these patients. So that reflex of thoracic outlet syndrome equals rib resection, I believe, needs to be rethought. And that's really the gist of your talk, if I could phrase it in short words.
Yeah, if I could inspire all of us to think about that and help us get to a more definitive answer, that would be great.
So the fact that you're having success with these other methods that obviates a rib resection is a good sign.
Yeah, right. We're excited about it. So just it's a brief summary, kind of what our technique is. As it developed over time: neurolysis of the plexus, subtotal anterior scalenectomy. We do a middle scalenectomy release off the entire rib. We decompress the subclavian artery, which is, you heard me say, is more of a now, as we call it, a arteriolysis, like the neurolysis of the brachial plexus. We neurolyse and identify every single time the dorsal scapular nerve, long thoracic nerve, and suprascapular nerve, as well as release the pec minor and the subclavius and the clavipectoral fascia. When we're doing just this one, we've we do this as an outpatient surgery. It's the first case of the day. We watch people 3 hours afterwards.
That's great.
And people do great, right? When we do a first rib resection, we do it at the hospital. They stay 23-hour observation and go home the next morning. So just as a comparison and differentiation, born out of some earlier collaboration with some friends at the Mass General Hospital. Kyle Eberlin, who is just a wonderful peripheral nerve surgeon at MGH and a dear friend, came out and visited to learn peripheral nerve, and he was really, really excited about our technique, and went back home to Boston, in the city that I trained as well, and started utilizing this technique. And we looked at our technique and published this paper jointly to kind of establish what we do. There's actually 25 steps that we outline in this paper. So I always give caution. I talked to Scott and Herb and asked if I should show some intraoperative pictures, and I think the idea is just to show some of the details, some of the anatomic variation, right? And I think that we're happy to share some of these pictures, just to have fun with that.
And after this, we'll get to our questions and answers for everybody who's watching right now.
Okay. What I always show this picture, because this is after getting down several layers and cleaning off some of the more superficial fascia. You see this is the upper trunk of the brachial plexus. You look in the books and it's spread out from side to side, right? It's all very nice. It's not like that in here. It's almost vertical. So this is kind of the first thing you see. You see the anterior scaling here. This is the phrenic nerve. You have to protect that phrenic nerve. You have to get in there. You have to remove this anterior scaling. You have to clean off the entire brachial plexus. The middle scaling is behind, right? So this is just kind of early picture of what you see. But when I'm talking to surgeons, I always say, it's vertical, not side to side. Now here it looks like more side to side, right? This side is medial. This side is towards the arm over here. But you can see the amount of what we've done and cleaned this off. Here's that upper trunk. You had a little window of upper trunk here, right? The anterior scaling was here. Here's C5, here's C6, here's C7, here's 8 and T1 to make up the lower trunk, and here's the artery. And this will give you a little bit of a picture of, like, you see this artery and you see this kind of rippled stuff up here. We haven't cleaned that artery off yet. We clean that off and you release that artery to and there's a profound difference between pulse pressure and pulse when you see it once you release the anterior scaling off there, then once you're able to release and do the arteriolysis. And even, I don't know if you can appreciate this, but this is the dorsal scapular artery that we had to ligate. And if you see how thick this is here, and then how it almost, you can appreciate an hourglass appearance in that nerve. That dorsal scapular artery is compressive, often to both the lower and the middle. On this one, it was just the lower. And Scott, you and I have talked about that anatomic variation, where I think if it's tight across here and that artery goes directly into the middle scaling, it's further tethering that. And so that anatomic difference is just one subtle little thing that we look at. For sure, if I see that that's tight and it's going into that middle scaling instead of going out and around it, I ligate it for sure. And there's just all these little subtle things and anatomic variations that you have to recognize in order to optimize and individualize surgical care for these individuals.
Hey, Rob, we're an hour in, so I'm going to suggest we go to questions and answers.
Yep. Let's do it.
We show your slide at the end so people know how to contact you through NeuroPax.
Um,
Okay, so
we're just
Rob is in St. Louis, the Neuropax Clinic. Anybody who doesn't know how to reach him can find him easily on the web. Just reach out to us and we'll put you in touch very easily. And Herb, if you would throw up some of our questions, I want to remind everybody that we don't answer specific medical cases here for obvious reasons, but we will try to give you a general answer to your question if it's about your care in particular. So, Brad, your first question today. Hi. What is your approach with muscle atrophy, CRPS, and TOS? And does CRPS presence allow surgery? This is a good question.
right. So chronic regional or complex regional pain syndrome, right? Type 1 or type 2. Type 1 is a centralized or centrally mediated type pain, and type 2 is a causalgia, right? So meaning there's an irritated nerve somewhere, right? And as a peripheral nerve surgeon, I tend to function in type 2, right? Because type 2, if there's a nerve that's, again, we go back to, is it compressed? Is it irritated? Is it, neuralgic? We can help those nerves. So when you talk about CRPS, you have to differentiate. Let's say that you have a diffuse, and when you talk about it inconsistent or with TOS, right? So is that pre-surgical or post-surgical, right? And are you, is it from trauma and you're trying to decide whether or not you're going to do surgery, or is it post-surgical and you're trying to decide, and you still have lots of pain and you're trying to decide whether or not you're going to do a revision surgery, right? So both of those scenarios exist. And in both cases, the CRPS does not obviate surgery in all cases, right? Sometimes when everything is just so flared, not a good idea, right? Not a good idea to go in and do surgery. You got to use some other modalities to get that pain down, block the centralized pain somehow, and get you to a point where you're not going to flare so bad and be so miserable, right? And again, that can happen after trauma as primary, or that can happen post-surgically as well. Scott, does that answer that question?
How about if there's muscle atrophy? Does that change your approach? And I presume we're talking about atrophy in the hand muscles.
That's interesting. So if you have no pain and you have atrophy, that's really late stage, right? So most of the patients that I see with atrophy still have considerable amount of pain, and we're surgery. We're offering surgery if we believe that's the diagnosis.
For the pain, but not to resolve the atrophy.
Yeah, well, I mean, it depends, right? I mean, what kind of atrophy, right? I mean, is it atrophy of the deltoid? Is it atrophy of the supraspinatus, infraspinatus? Is it intrinsic atrophy of the hand, right? Depending, every bell-shaped curve for each one of those, severities, each one of those muscles, right? And depending on, you can get some of that back, right? I mean, that's, it really just depends on where you are on that, on the development of that. Yep. But a lot of times people will just have, they're not using it. The quotes of the patients: my dead arm, my arm that's dying on a vine, my arm that I don't use, my arm that I call the other guy's arm, right? Huh. That promotes disuse atrophy, right? That alone, if a painful limb you're not going to use, you're going to have some level of atrophy alone. That's recoverable. Right? If you're treating that patient, that's recoverable.
So I'll reinforce the fact that there are TOS skeptics out there who will say, unless you have a positive EMG and atrophy of your intrinsic hand muscles, you cannot have TOS. And I viewed it as you do, that it's really end stage. It's late in the course of the disease.
If you wait for that, you've missed the boat, right? Yep. If you wait for distinct atrophy in the hand and a positive electrodiagnostic study, you've not done that patient any favors.
And there's very little likelihood of recovery even after successful surgical decompression. So, right. So in terms of patient awareness, it's good that they don't give up when a doc tells them that. Brad asked you, how successful are the surgeries for severe neurogenic TOS? And is a good question. Again, how does that translate in normal daily activity and functionality?
Well, I mean, again,
Audio?
any chronic peripheral nerve pain problem we're taking care of, we're going to get them back to sleep, back to life, back to work, right? And that's our goal. And even for severe NTOS, if you're seeing that in a reasonably timely fashion, you should be able to get back to daily life function for sure, right? I mean, that's our goal. I mean, if we couldn't do that, I don't know that I'd be in this space.
Good. Excellent. TOS Unbound, who was here last time. Hi, good to see you again. Not to ask a very general question here, but from a surgeon's perspective, is TOS often misdiagnosed as carpal tunnel or cubital tunnel in your experience? It's a good question.
Often's a pretty highly variable word, but let's say it's not uncommon for us to see patients that have had cubital tunnel and carpal tunnel surgeries, and they're considering even revising those when maybe the true diagnosis was TOS. That's one of my soapboxes about understanding that whole limb. If you were TOS Unbound, if you saw that earlier, just about the whole arm and the shoulder and the neck, that's been, I think it's just understanding the whole extremity. And, we'll see patients, they'll say, well, everything was negative, but we just figured we did a cubital tunnel and a carpal tunnel just to see if we got any benefit, right? Like, right. This happens and it goes on, and it's all we're just trying to help, right? And they want to help people out of pain. But understanding, all of the diagnosis in the chain is very important.
And I wonder if this is based on the medical literature. If the question is coming from the medical literature, it's a good one, because there's a decent amount of medical literature on the fact that people who get surgery for carpal tunnel syndrome actually have thoracic outlet syndrome and may not have needed the distal surgery once you relieved the proximal stuff. So it's a great point. People who have had, I'm sure you've had patients came to you carpal tunnel syndrome, then carpal tunnel surgery. They did great for 6 weeks, and now they're getting pain, and it's more proximal on top of that. Sorry about the audio, folks.
Yeah, I don't know. We talked about that earlier. Like, they can coexist. It's not uncommon for people to have distal compressions as well as the proximal compression.
But
right?
multiple crush means that the proximal compression makes the nerves more sensitive to even less compression distally. Is that?
Yeah, that theory. Yeah, multiple crush concept is not just multi-level compression, right?
It's that it's kind of a chain.
Is that, to your point, is that a proximal compression makes the next more distal compression more vulnerable to occur.
Right? That's a great way to describe it.
Right?
Thanks. All right. And same fellow, I think it's a fellow. I have found biceps tenderness to be really common in TOS patients, but not cubital or carpal tunnel patients in my clinic. TOS Unbound, can you tell us what your specialty is? You can do it in a comment. We'll answer this. So have you found bicipital tenderness, Rob?
Yeah, I mean, bicep tenderness is related to the C5 in the upper trunk. There's actually a variant of TOS that I call, with upper trunk predominance, right? And those people tend to have lateral shoulder deltoid pain and biceps pain, and they have weakness there, right? And so, I'm looking at that. So.
Thank you. TOS Unbound is an exercise physiologist. So,
yeah,
as I suspected,
awesome.
A very educated person.
Love your questions and your comments. So.
Can you go back to the previous one? I'm an exercise physiologist, and I have found a point he was raising. There you go. Oh, he's got more questions. Actually, it was something else you were talking about, injections, I think. All right, so let's try to unbundle a lot here. There we go. I believe the injections work because the antagonist muscles, like the upward rotators, are weak. It's a very interesting point. So you get imbalance of the muscles.
Yeah, Patty Zorn, our physical therapist, is big on that, right? She's the trap, whether it comes primary or secondary, right? We talked about those persons with a lot of that pain take tension, I think, off of the plexus by holding it forward and down, right? So that kind of augments the contraction of the pec minor, weakens the trap. So I think she would agree with you. And
So
we work hard on that. We always say this is really important. Post-operatively, we can do all that decompression, but if they don't re-strengthen their trap and their posterior shoulder muscles and get it back into the right spot, you may not realize the true benefit of the surgery.
TOS Unbound, that's really good. Do you believe, and you can answer this in a comment, that the upper trap and serratus being weak, do you think that drops the shoulder girdle relative to the rib cage? So you can answer that. And also, do me a favor, reach out to me through my website. Let's have a chat. I'd love to hear more about what you're doing. Okay, we can get back to that. Tim Bitts, exclamation mark. What are the risk factors for TOS surgery for someone in his 70s? Does it depend on the skill of the surgeon versus many different neurosurgeons? So I'm guessing, and maybe you can clarify for us whether you're asking how to find what qualities in a surgeon make him or her more likely to be successful. Maybe that's the question. Rob, what would you say are the factors to ask for in a surgeon?
Well, I would just say is the surgeon focused on that, and they open-minded. I think having a stratified care kind of approach is important. I think just being thoughtful in the diagnosis and thoughtful in structuring what the treatment plan is.
Are there greater risks for a 70-year-old person than there would be for a 25-year-old person beyond the obvious, medical surgical risks?
Just the general surgical risks, right? I mean, every decade that we get older, there's some level of risk that increases. I think if in that age group, and I admittedly don't see a lot of 70-year-old TOS patients for whatever reason. But when we do, it's more of a postural thing. It's usually that the posterior shoulders are weak, and the scapular depressors are tight, and that just pulls that shoulder. I say it's sliding off the mountain and puts a lot of tension. So many times when we're seeing a patient of that age group, unless it's true trauma induced, they're responding well to therapy.
And when you talk about stratified care, you're obviously talking about starting out with injections or less serious things and going straight to surgery and having
Absolutely.
a plan in place to get relief with lesser degrees of invasiveness.
For sure.
Okay, thank you for the question. All right. At 8 p.m. today, Tim Bitts asks again, today's surgeon, Dr. Hagan, put up a slide highlighting 3 areas of nerve concern. One of these is labeled LTN. Does that highlighted affected area include the underarm lymph gland pain?
Yeah, so again, that was one of the areas that early on that would continue to have pain was the posterior shoulder, and then how it wraps down around into the axilla, particularly on the chest wall. And the long thoracic and that serratus anterior muscle match up with that. And we know that when a nerve is irritated or compressed or tethered, even if it's a motor nerve, that can cause achiness into that myotomal distribution, so to speak. So that long thoracic nerve, again, we identify it every single time, right? We release that middle scaling, and then we identify and neuralize the C5, 6, and 7 contributions to it. 1, to protect it, and 2, to treat it.
So the long thoracic nerve, the suprascapular nerve, the dorsal scapular nerve, nerves to the subclavius and pec, these are all branches that come off of the brachial plexus. In general, viewers, when I show pictures, when Dr. Hagan shows pictures, we look at the 5 biggest structures, the 5 nerve roots, C5 through T1, and they form trunks, and then they form divisions and cords and nerves. But all along, there are these smaller branches coming off. What Dr. Hagan's describing, the long thoracic nerve, are branches from each of C5, C6, and C7. And the serratus anterior muscle rides on the first rib and along several ribs here under the armpit, as is being asked by Tim Bitts. And so injury to those nerves, or if you've had surgery and the nerves were injured, or if they're being compressed, and it can cause this kind of weird aching, non-localized pain in that area. But when Rob Hagan is describing all the dissections he does, those are very complicated nerves. It's a very complicated network. So that's why it's so important to have somebody who's detailed for something like this.
Yeah, that long thoracic nerve, I think, is the one that you have to really be very, very careful as you're.
It's quite variable in different patients, isn't it?
Right. It's so variable, and it's buried within that middle scalene, and it's just the one that I really, you're thoughtful through the whole thing. I'm particularly thoughtful in finding those branches for the long thoracic and cleaning them.
Thank you for the question. Tams 1212. My injury is from a car accident. I was T-boned on the left side and landed upside down 27 months ago. Been off work since. Major pain and muscle weakness. So I'm not sure of your question, but car accidents are one of the most common causes of TOS. What we find, I'm sure you'll agree with me, Rob, is young people who aren't likely to have disc disease, they're more likely to end up with TOS after a trauma like this. Once you get about 55 or 60, then all the degenerative stuff adds in.
Yeah. So the younger people, number one cause of a neurogenic thoracic outlet in my patient is either a whiplash injury acutely or even remotely, many years ago.
And by whiplash, we're just talking about the mechanism.
Yeah, the mechanism. I mean, she was T-boned and rolled, right?
Yep.
There was significant energy in that accident that was translated to her body, right?
Yep.
And
I've described this before. Your neck muscles hang on as tight as they can, but your head is usually pretty heavy, and your head is going to rock back and forth, and those muscles are going to clamp down really tight to hold things in place and protect the neck. And they'll get micro tears and they'll swell up.
That's well documented that fibrosis and that anterior scalene
Right.
pathology study that was done showed fibrosis in the anterior scalene after those types of injuries.
Right. Sanders did one, and then the docs, I think Mockleader did it in LA. They showed the same thing.
That's right.
When you look at electron microscope after trauma, those muscles are just structurally different. Yeah.
We see that. I mean, it's visible. We see it in those muscles as we're releasing it and coming across with the bipolar. It's like,
They look really tight to you.
Yeah, for sure. In certain patients, we definitely see that fibrosis. You can palpate it sometimes. You can hear it just as you're coming through the muscle sometimes.
Another reason to get patients to you early.
Yeah.
Okay. Thanks for the question. TOS Unbound is back. That occipital pain is likely because it is where the upper trap attaches to the skull. Of course, it will be sore when the scapula is downwardly rotated. The upper trap is being stretched. So TOS Unbound is saying, these occipital headaches, at least in part, are due to severe muscle tension pulling on the fascia.
Yeah, no, I agree that, but they differentiate that, right? So people will say I have a headache or I have the hockey stick pain. I call it the hockey stick pain, where it's kind of up and down. So I think that description that you're talking about is part of that hockey stick pain that we often see. So great comment.
Haven't you also written a paper on the little foramina, the little holes in the fascia around the occipital nerves?
Well, meaning, wait, so
then when those, excuse me, there are little spaces, little holes in the fascia for the nerves to come out to penetrate.
Yeah, no. So we part of our practice and overlap or the
And you wrote a paper on this, right?
we've been looking at occipital we've looking at occipital neuralgia for a long time, so for sure.
So if you have these holes in the fascia and you start shearing or pulling on them, they're going to compress the nerves at that point.
Yeah, I mean, one of the papers, you're probably thinking of it, we looked at the oblique capitis inferioris muscle and it's how it's incriminated as the most proximal point of tethering or compression on the occipital nerve. And really, we're looking at that in the context of these types of injuries that we're discussing,
Okay.
The whiplash.
Thank you for the question, or the information. I'm a believer. Hi, can AFib, that's atrial fibrillation, atrial flutter, and other arrhythmias and lower extremity weakness be contributed to a diagnosis of neurogenic or venous TOS? So let me separate those. Have you seen dysrhythmias or arrhythmias in patients with TOS?
Not notably. Again, I've not seen that. But what we have seen is, I think when sometimes when that artery is getting compressed, I'm thinking of one individual that had, when we raised her arm, she would and occluded, compressed the nerve and occluded her artery. She got very centralized symptoms. She got dizzy. She was going to fall down. She felt her heart racing, all these kinds of things. There were some very centralized symptoms, right? I've not had somebody that and maybe in an individual that's vulnerable to, when you have that compression or that irritation, that you can trigger that. I think you can draw a line between the two. That said, we don't see that.
Okay. As to the question, I'm not familiar in the literature with there being a strong association there. How about lower extremity symptoms of any sort? Have you seen those in your TOS patients?
Not usually, other than, in some subpopulation of the TOS patients, meaning that they're vulnerable to compression neuropathies. For instance, diabetic population may be vulnerable to having lower extremity compressions as well. There's lots of studies out there showing that, lower extremity, what we would say diabetic peripheral neuropathy with overlying compression neuropathies, this patient population is also vulnerable to having, post-surgical neuralgias and neuromas, and would be more vulnerable to having things like neurogenic thoracic outlet.
I'm a believer. I can tell you that one of our local docs who recently retired, a Dr. Newkirk, he did believe that there were lots of patients, relatively lots, but there were patients, a decent amount, who had lower extremity symptoms. And he believes that it's due to some spinal cord congestion. And it's a question that's not answered yet. But I work with a few docs who believe that the veins get compressed and then it alters the nerves in the arm. So that may be happening elsewhere. Right now, the literature doesn't have a lot on lower extremity symptoms. Thank you for the question. Sue, hi, Sue. Could left upper limb C5 through T1 sensory motor loss after having a CT and RT surgery be TOS? I presume it's I still have pain, tingling, numbness, left arm and hand, nerve conduction tests say altered median nerve function. So I want to remind everybody we can't answer specific medical questions. We can talk about this in generality. Left C5 and T1 sensory motor loss. It would depend after the cardiothoracic surgery.
Is that carpal tunnel and radial tunnel?
Maybe, yeah. Yeah, so, okay, good. So that fits more into our questions about multiple crush.
Anytime multiple compression neuropathies in the distal limb are diagnosed and you have surgery and they're unsuccessful, you need to look more proximal. Again, especially in the context of, was there a mechanism of injury that would maybe induce that, like, a fall, a whiplash, a traction injury to the arm and upper extremity, some level of repetitive working at or above your shoulder level or power zone. All those things are things we think about. Yeah.
Okay. Thanks, Sue. Hi, Freya. Are there risks to be aware of when considering surgery for bilateral TOS?
And for bilateral TOS, I think you have one. I don't know that anybody would do it at the same time. I think they're the same, right? You have one side, and you don't do the other side until both you and your surgeon and those around you are 100% sure that you've had some level of significant benefit. Once everybody is on board and feels that you've had some significant relief, then I would consider the second side.
There are, of course, Freya, general surgical risks, bleeding, infection. I don't think you're asking about those. Each surgeon is going to have different risks because every surgeon has different approaches, right, Rob?
Mm-hmm.
And Rob's been a student of many of these approaches. His is rather detailed because of his training. He's a peripheral nerve surgeon, right? Some surgeons take a look at big picture. I'm taking out a big hunk of that first rib. I'm going to clean out everything. And that's a different kind of risk. In the literature, the specific risks would be a pneumothorax or an air leak because you are close to the top of the lung. That's pretty uncommon. What's called a chylothorax, a leak of lymph, which comes up the left side, and fairly uncommon. I don't see those very often at all. There is some nerve damage. Dr. Hagan had mentioned the phrenic nerve, which controls the diaphragm, which controls breathing. So most surgeons are very careful around that nerve. If it does get injured, you could have several months where your diaphragm is weak. Usually it recovers, right, Rob?
Yep.
Okay.
That's the one I'll spend most time in talking to people about, is that phrenic nerve. And in our practice, we've done several hundred of these surgeries, and we probably have 5 or less phrenic nerve injuries, and only 2 of them have gone on to need something. And I can tell you, we treat that phrenic nerve so carefully. In the 2 individuals that have needed something, they were a higher BMI diabetic patient. So I spent a lot of time counseling about that. If I think the individual falls into that category, I don't know that anybody is more careful with that phrenic nerve than we are, and we still see some level of irritation to that. So,
there's a movie called The Hangover, and there's one scene where they leave Galifianakis. What's Galifianakis' first name? I forget. Very funny guy, but just he always plays weird characters. He's hanging out by this beautiful vintage Mercedes. An old man walks by and says, "Wow, that's a beautiful car." He says, "Don't touch it. Don't even look at it." And I think about that when I think about the phrenic nerve.
We're often through the whole thing, we never even lay a retractor on it. When we retract it, we put it above the tissues above, and then we pull that tissue up, and it lifts it up out of the way. We don't even touch it, and we constantly know where it is. Especially when you're taking out that anterior scaling muscle. And
good, excellent. Thanks for the question.
Don't even look at it. Don't even touch it. Don't even look at it. That's going to be in my head now.
When TOS Unbound asks a question or provides a comment, I expect something good. Our standard is high for you. My approach to treating TOS addresses the full body. I'm not sure if you've heard of postural respiration, but that's the area of study I try to combine with traditional exercises for treatment. So postural respiration. Before you answer this, Rob, I will point people to the past talks we've had with Steve Talikowski, who talks about posture and more importantly about breathing. And so TOS Unbound, I'd love to hear more about what you do. Reach out to me. Maybe you want to contribute to one of our talks in the future. But Rob, how do you work with your physical therapists and address posture and breathing?
I think these are great points from TOS Unbound. We work with our physical therapists very, very closely. It's that whole thing. We're all so forward. Our posture is so, do it. I look at my own, when there's wrinkles in my, my shoulders need to be back. Everything is forward. And when you're forward and clammed down, taking big deep breaths is hard versus taking a big deep breath when you have good posture, and you guys are the champions of that, in the sense of like helping us on the front end trying to obviate surgery, and then if we can't avoid surgery, how do we get that person back into better posture afterwards? Because if you're not part of the team helping us do that, like I said earlier, sometimes you don't even realize the benefit of the surgery if in fact that's not accomplished.
That's great. And I think that people with TOS adopt an abnormal posture as well, don't they? They have a different center of gravity because of that primary rolling the shoulders forward.
Yeah.
So that's good, TOS, that you address TOS Unbound, that you address all that. I think that is an important part of it.
And to her point about his or her point about the full body thing, people get deconditioned, and I couldn't agree more with, once you kind of get them, to a certain point with their own upper extremity posture, and then start how do you do all other activities and still remain in good functional position?
Excellent. Thank you. I find that patients tend to have one side with a weak oblique or poor rib cage expansion. Areas I'm still looking into are inhalation bias, how pelvic tilt affects the rib cage and shoulder. So more of a whole body approach again, I think, if I'm speaking, sorry for somebody else. But I guess you're suggesting that asymmetry is part of this chain where you have abnormal breathing and then you assume abnormal posture. Is that fair? Okay, we're going to juggle now. I'm going to go back, and TOS Unbound, come back to us. TAMS 1212. Yes, I have damage to the anterior scalene. Is this TAMS who had the car accident? I think so. So damage to the anterior scalene that Rob was talking about, is common, and it makes it, if it stays permanent, if it's not treated, the muscle is just permanently shortened and tight, changes the position of your neck and your first rib, and can take up space that the brachial plexus needs. And I will say that it's something you mentioned before, Rob, which I forgot to mention, but you talked about upper predominant TOS. The nerves, all the nerves in the brachial plexus can take variable courses. And we see this on MRI, but the ones that most commonly do so are C5, C6, and the upper trunk. I'll find them going anterior to the anterior scalene or through the center of it. So I just want to point out that this is another variant of TOS. Okay. TOS Unbound says yes. Thank you. When is surgery not necessary? This is good.
That's a pretty big, quick question. I love the old saying, it's easier to know when to operate than it is to know when not to operate, right? So sometimes you'll be sitting in front of a patient with a spectrum of information, and sometimes it's very obvious that you need surgery or you would benefit from surgery, likely. Sometimes it's really confusing and you want to help the patient, but you ultimately know you shouldn't do the surgery. Surgery is not necessary when you resolve your symptoms with conservative modalities, right? But if your index of suspicion of your working diagnosis being TOS, neurogenic TOS, is high, right? And all other things have failed, then you're likely going to end up with surgery.
I think we've lost your audio, Rob.
I said, well, not, it's a big stroke question, right? So it's not necessary when you've cured it without it, right?
And that's why the stratified approach that you take allows for those decision points at multiple places along the course.
We're as proud to get somebody cured or better without surgery as we are with surgery, right?
That's great.
We need to be able to show that we can do that, and it's fun either way to help somebody.
So some of those procedures we talked about before, like hydro-dissection, can obviate surgery.
Mm-hmm.
Good physical therapy, in some cases, can obviate surgery.
Yeah, as we're seeing these patients earlier and earlier, I think those modalities are more meaningful to that patient population.
Excellent. All right. And this is easy. I'm being facetious here. Who is the best type of specialist to see to diagnose TOS?
What type of TOS? Right?
Okay, so she says she's seeing an orthopedic surgeon on the 15th. Okay. I'm going to throw in my 2 cents first, because I think Rob's going to favor kind of one type of surgeon. I think, first of all, what you all folks are doing here, advocating for yourselves, educating yourselves, asking questions, is a big critical part of this. Okay. Any one doctor, don't take that one doctor's word for it. Okay. There are many specialists who see TOS patients. I say this all the time. Historically, it's never been owned by one type of doctor, but the different docs, we're learning more and more, have very different approaches. Now I'm going to give it back to our peripheral nerve surgeon, Dr. Hagan, to talk about maybe the docs you work with locally and how you refine that diagnosis from index of suspicion all the way to a specific diagnosis.
So I mean, I think to your point, Scott, there's multiple different specialties that end up seeing these patients that that can make that diagnosis. The key is if they say no, it isn't. You know, are they a person that has seen you know, a lot of these individuals, and can they really say that? You know, so it may be really geographically dependent on, you know, a specialist. Like you could go to Scott, he's a radiologist, right? And he's going to diagnose you much better than many other individuals and many other orthopedists, right? You know, we see patients. We didn't the misdiagnosis even in the underneath the umbrella of TOS is pretty high. So what we do is we end up seeing any patient that has a diagnosis of TOS if they haven't had an appropriate workup and evaluation, because venous TOS or true arterial TOS, in addition to neurogenic, and if we identify those, we'll send them to the vascular surgeon. Absolutely, right? If we think it's neurogenic and it's appropriate for us to continue care, we will. So I wish I had a better, more definitive answer, but it's about finding the individual that's committed to and seeing a lot of these patients. You think that's fair, Scott?
You said it great in the beginning. Let's start off with the ones who say you don't have TOS. Those better be really experienced people. Okay. There are a lot of docs who don't see TOS. This goes way back to the beginning of your talk. There are docs who don't see it. And if they don't see it, it doesn't mean it's not there. Maybe they just don't see it. I'll share a funny story from a court case I did years ago. There's a local doc who's very skeptical that TOS exists, and he was an expert witness in this lawsuit. He got paid a lot of money for doing that. And the attorney who was working with me said to him, so I understand you're an expert in TOS. And the guy said, yes. Said, does this patient have TOS? And he said, nope, absolutely not. He said, do you see a lot of patients with TOS? And the witness says, no, it's very rare. In my 30 years of practice, I've seen one case. And so the attorney looks at him and says, so you're an expert. And that's the way it works. People like Rob have seen a million cases that are clearly TOS, cases that are clearly not, and those arbitrary cases in the middle. There are different docs in every city and different specialties. So I wouldn't focus on the specialty. I would focus on, does the doc have experience? And then when you talk to the doc, is he or she knowledgeable? I mean, you folks ask questions that are really good questions. Clearly, you understand what's going on, and you have the resource of Dr. Google. So be prepared, ask questions, be nice, be polite. If the doc doesn't know something, does he or she say, I'm going to have to look that up? Or do they just dismiss you? So part of that is judging if the doc is open-minded, because none of us knows everything. The second thing I'd say is don't worry about the specialty as much as does the doc have TOS experience. And then finally, go to resources like us. Email us. We'll send you a list of docs in your area. We'll send you contact information for how to reach people. Rob, out of curiosity, do you do video consults?
Yeah, we do telemedicine. You know, again, born out of post-COVID era, we've learned to utilize telemedicine, incredibly well. We have a port, like an access port on our website. You can go and kind of fill out a patient inquiry, and then that kind of can help get that set up. I actually quite enjoy it. I've learned every Thursday morning, I see telemedicine visits from across the nation.
That is great. So we've got an expert right here who I can tell you is very experienced, very open-minded, very progressive. Great person to see for TOS. Same person. My physiatrist says my ultrasound is describing TOS, but because my EMG, that's an electrodiagnostic test, months ago came back negative, he says it's not. I am so frustrated with the docs in Canada. He is wrong. First of all, EMGs, without going into this story in great detail, TOS was first described a little bit over 200 years ago, and there was no problem. Some of the most famous names in the history of medicine have researched it at times and published papers. In the 1980s, a guy at the Cleveland Clinic who had a great reputation, was a neurologist. He said, I took a bunch of these patients, I did EMGs, the EMGs were negative, they're faking it. The surgeons seeing these patients are doing it for money. And it started a dumb conversation in the literature with a guy named David Roos in Colorado, a surgeon with a lot of TOS experience who pioneered a lot of this stuff. And he kept saying to the original neurologist, he said, well, then what's your answer? What do they have? To which there were just crickets. So unfortunately, what's happened is that neurologist said, I'm going to set up a new classification. There's arterial TOS, venous TOS, true neurogenic TOS, where your EMG is abnormal and you've wasted the muscles in your hand, which by then it's too late probably. And then disputed TOS, where you don't have a positive EMG and you don't have the atrophy in your hand. Now, I'm sure Rob will tell you, most docs will tell you when you have a compressive neuropathy, you prefer to treat them before they get atrophy of the muscles, right? You don't want to be at the end stage because it's rare to recover. Secondly, EMG for a lot of reasons just doesn't work in TOS. So the fact that it's negative TAMS, forget it. It doesn't matter. If it was positive, maybe it would point you to something like a cubital tunnel syndrome. That's what Dr. Hagan said before. The other thing I'll say is ultrasounds of the arteries can be negative, completely negative, and you still have neurogenic TOS. Compression of the artery does not equate to pressure of the nerve. It's the basis for Adson's test, where he looks, Adson in the 1920s would hold the radial pulse and move your neck and have you take a breath and try to make the pulse go away. But he didn't have ultrasounds, CAT scans, MRIs in the 1920s. Now that test is merely suggestive. In your case, ultrasound is positive, but none of these tests will show specifically what's going on. So clinically, if your doc suspects TOS because you have this broad range of symptoms, then go to see an expert who really knows enough when to say no and when to say yes. That's my 2 cents. Rob, after all my 2 cents, you got something to add?
We get an electrodiagnostic study on everyone, nearly everyone. We do not use it to diagnose neurogenic thoracic outlet syndrome. We use it to make sure it's a layer to assure us or add to not missing some cervical pathology and downstream compression neuropathy. The only other cases that we're looking when you have a true brachial plexopathy, which is an intrinsic nerve damage. Maybe there's so much traction on the brachial plexus that it actually shows up on the electrodiagnostic study. That's an important additional information. But most of the time, 98% of the time, we do not use electrodiagnostic study to diagnose neurogenic thoracic outlet.
And to add to that excellent question, the intrinsic brachial plexus thing is an inflammatory disease. Sometimes, what is it, Parson Turner? I've seen like one case of it so far in my career. Very rare.
Post-viral.
Right.
Yeah.
Right. So you get a virus and then you get this neuropathy that's probably mediated by the immune system. Very rare. We consider TOS as extrinsic. The plexus starts out normal, but it's compressed or stretched, and then all these secondary things change. But regardless, you don't get an abnormal EMG till late in the disease.
Yeah.
All right. Jane Kim. Hi, Jane. Why are there so many physicians who do not believe in TOS? what can be done to improve awareness among the general medical community? So first of all, TOS is tough to diagnose. It is complex. And I'm sure you've seen patients, Rob, who emotionally are just so freaking frustrated, right? And that turns doctors off when a patient comes in and they're needy. They're needy because they've been blown off by 5 or 6 docs. So those patients unfortunately get pushed away, and harder for them to break through the physician's belief level. But just because you don't believe in it doesn't mean it's not there. That's ridiculous. I've had these discussions with docs before, and sometimes I have to ask them why the brachial plexus is immune to compression. Every other nerve in the body can be compressed. Why can't the brachial plexus? And I usually get the response something like, "Oh, you just don't understand," and then they walk away. So besides the story I just mentioned with the disputed TOS, that's a ridiculous non-scientific approach. And I'm just going to say this once: people who say disputed TOS, it's disputed, they're intellectually lazy. If they read just a little bit of the thousands of papers that are out there, they would understand that it's absolutely real. Rob, that's my soapbox. I'm getting down now.
No, I think you're right. It's hard, and it kind of goes across different. We each have stories about, there's a cervical spine surgeon here in our town who just doesn't believe in it, and literally told a patient that they must, if surgeons are doing this, they must need a new car or something. Just literally. And has misdiagnosed many individuals, unfortunately. And that said, he's a very good spine surgeon. He just, when he sees a TOS patient, he does a face plant and can't diagnose it, and doesn't believe that it's there. So we're often dealing with that, whether it's not often. I think less often are dealing with that, but we're still dealing with that. Whether it's a spine surgeon or neurologist or shoulder surgeon, whatever. But I think most surgeons these days are open-minded to it. So part of our overall burden is, to your point, how do we get this out more? And the patients that go back to that have a great experience and go back to their providers that either missed that or said they didn't believe it, I think is one of the most impactful ways to spread that back. I think I shared the earlier on the social media. I've learned is just incredibly impactful. So I don't know what the answer is, other than
agree with everything. Let's face it, right now we're getting some high-end athletes being diagnosed with TOS. That's helpful. People are more influenced by a Kim Kardashian than they are by a Dr. Scott Worden. I don't know if she knows more about TOS than I do, but hopefully she's on our side if she does. This social awareness, and again, we get people like TOS Unbound, obviously a trained professional who's been seeing TOS for a while. Those kind of people, I find, Rob, sometimes are more aware than physicians. Have you had that experience with physical therapists and other providers?
Yeah, I mean, the physical therapists that we work with throughout the area are so open-minded, so patient-centric, understand nerve. They are eager to learn more about it because they're frustrated when they get these patients and they hit the wall and nobody's establishing that diagnosis. Yep. So, the physical therapists that we work with, the chiropractors that we work with, the just the spectrum of care providers that are hungry to help. Or the network that we need to engage.
Yep. Don't let anybody stop you, and all of you keep spreading the word. Help out on social media. It's great. TOS Unbound, that's so kind of you. Love your approach to evaluating professionals, Dr. Scott. Well, again, I'll ask you to reach out to me. I'd love to have a chat with you. Freya says, my acupuncture is diagnosed, neurologist confirmed, ultrasound showed, vascular surgeon doubts because EMG didn't show much, and bilateral TOS is rare, but wants to do surgery just in case. Okay. I will tell you from the imaging point of view, where I'm at least qualified to speak, even when patients come in with unilateral syndrome, unilateral symptoms, or dominant on one side is much stronger than the other. Their anatomy is usually bilaterally symmetric, maybe a little different on each side. But if a patient has severe enough anatomy to have compression of the plexus, they'll have something on the other side that's pretty darn close. And in my experience of following up with patients after surgery is they'll do better on that one side that's been operated on, but now they start noticing the other side, either because it's unmasked from the loss of pain on the first side or they're more active. So it's not rare. Bilateral TOS is not rare in my opinion. Rob, any thought?
Just regarding the bilateral TOS?
Yes.
Yeah, it's interesting. I see it. It's probably 10 to 20, maybe 10 to 20% in our practice. And usually the one side's more minor than the other. And often when we treat the worst side, the other side gets a little bit better. I think there's a little bit of a crossover floodgate confusion centrally. So we'll try very hard to treat that opposite side with physical therapy and conservative modalities. But obviously, if the anatomy dictates that, to your point, if there's a residual cervical rib band on each side, inside that middle scaling, and they have anatomic predisposition, we're ultimately going to do surgery on both sides.
If your surgeon says, you can drag me kicking and screaming into the OR and I'll do the surgery, maybe you want to get a second opinion before you go that way. Just a thought to make the best choice. And, all the patients I speak with, even if they pick a great surgeon like Rob, other people I work with, I usually encourage them to get a second opinion because it's good for your confidence. You did your research, you know how docs think differently. Most of the good TOS docs will say, sure, get a second opinion. Here's how I approach it. I'm glad to talk with you about it.
I have a low threshold to encourage people to get a second opinion. If your doc is offended by that, you should move on along. I encourage. I love the line. You're the chairperson of your own board of health. We're all just board members sitting at your table, right? And our job is to give you the best information that we can. Ultimately, you have to make that decision, and we're part of your team to move forward.
I wish I could put that in a promotional commercial. It's a great way to put it. Yep. And it's about you, the patient, not about us.
Yeah.
Freya also asks, how will I recognize muscle atrophy on my own? How will a doctor diagnose atrophy? I think it's better to have a doctor diagnose it. I mean, you may see it, but a good doc will examine you for strength and reflexes. If they know what they're looking for, they'll look for differences in the muscles, but it also depends where your disease is, which muscles would be affected. I mean, you can see pictures online of people who have narrowing between the muscles of their hand. That's kind of classic for TOS, but it's pretty rare because it's when the TOS is very advanced. Herb, do we have other questions? We let people know that Dr. Hagan can be reached at neuropaxclinic.com. That's Neuro, neuro, PAX, clinic.com. He's a great guy to talk to. He knows so much, very personable, as you see here. And absolutely a great resource for TOS. I love hearing more about what you're doing, Rob, with your gradient approach and how you work your way into these. And hopefully we get to work together a lot more because it's really stimulating for me.
Well, I love every one of our discussions. I'm grateful and I'm honored to have been invited on to this and discuss with you and for all the folks out there. I'm truly grateful.
Thanks. We're gonna put you up on YouTube and on our web pages. Save you for posterity. You really add to the richness of our resources for patients. I really appreciate it. All right. And then I'll remind people that is thoracic outlet syndrome rare? That's one of my talks coming up on September 13. We'll be having Dr. Vernon Williams again soon from Cedars-Sinai. I'll find the exact schedule for that. And I think we're working on Dr. Art Jenkins from New York. All people like Dr. Hagan, really smart, really smart. They scare me and really good with TOS. So good talks coming up. Please hit the subscribe button. Please mash like. I think that's what they say on YouTube. Help us out. go to our other social media like Instagram and Facebook and Twitter, TOS MRI. You can find us on all of those. I'm trying to post more blog posts and trying to get a little more active on Twitter, which I've never done before. Thank you, Sue. I appreciate that. I thank everybody who's attending and asking good questions. And until next time, I'm the TOS guy, Dr. Scott Worden. Thank you so much. All right. Rob, see you soon.
Cheers. Thank you.